Cabrera. I'm one of the pediatric endocrinologists. Today, I again apologize with our adult colleagues because, as you know by now, I like to talk about growth, right? And adults are not growing anymore. So today we'll talk about the title of my talk is Small Beginnings, Big Impact, uncovering the complexity of SGA birth. So SGA means small for gestational age. So we will review the definition of SGA birth, and then we'll talk about like other different terminology that sometimes is like easy to confuse. We'll talk about the etiology of short stature after SGA birth. Then we'll discuss the different short-term and long-term health outcomes of SGA birth. And then at the end, we'll talk about the recent guidelines and the available literature about treatment strategies for the management of short stature in patients that are born SGA. So a little bit of background. So globally, about 16% of infants are born small for gestational age. There is a wide range from 7% in developed countries up to like 41% in South Asia. And we know that size of birth and then postnatal growth are important indicators of neonatal and then adult health. Children, you will hear these multiple times like throughout my talk, but SGA infants have increased risk of negative developmental and then adult health outcomes that we will review today. So, few definitions. So, low birth weight refers to any infant with birth weight less than 2,500 grams, regardless of the gestational age. Less than 2,500 grams, that is low birth weight by definition. Now, SGA refers to having a birth weight and or length below -2 standard deviations for the gestational age. So typically we use the growth charts from like McLean and Usher. These are here on the right. We can see like the little light blue line here, that's -2 standard deviations. So like anything below that will be considered SGA. So here is birth weight and here is length. And then IUGR that I feel like we often tend to confuse with SGA refers to basically poor weight gain and then poor growth of abdominal circumference between point A and point B during pregnancy. So like on 2 separate ultrasounds, there's just not enough gain of weight between 2 points. And that's actually regardless of what the birth weight is. So most, but not all infants with a history of IUGR on different ultrasounds will be born small for gestational age. So as far as what causes SGA, so there is a complex interaction between maternal factors, placental issues, and then some fetal factors as well. We know that maternal health and is actually like highly associated with birth weight. So we see higher rates of SGA birth in moms that have chronic issues like chronic hypertension, those that have preeclampsia during pregnancy, malnutrition, hypothyroidism that goes untreated, infections, and then in developing countries, malaria. And then there are multiple, and I feel like every day there's newer and newer symptoms are described that are highly associated with SGA birth. So I'm going to talk about some of the genetic causes of short stature after SGA birth. I think you might have seen a couple of the slides that I'm showing here. So it's easy to classify this in like 2 separate groups. So there are monogenic causes of short stature after SGA birth, and there's imprinting disorders and methylation defects. Of those that have monogenic disorders, we can subdivide that in those that have like a normal head circumference and those that have microcephaly. Of those that have normal head circumference, we can further divide those in proportionate short stature and then disproportionate short stature, and that kind of like will guide us clinically of like what things we will suspect. So of patients that have monogenic disorders, normal head circumference, and proportionate short stature, so probably very hard to see because it's very small, but there is a list in here. I know that some of you are thinking growth hormone deficiency does not present with SGA birth, and that is correct. Some of the genetic causes of growth hormone deficiency, including mutations in the GH1 gene or the growth hormone releasing hormone receptor gene, tend to have like a little more severe phenotypes, and the babies are smaller than average, but typically do not fall into that category of SGA birth. Laron syndrome is similar. So this is due to mutations in the growth hormone receptor. Again, they're typically smaller, more in length than weight, but most of them will be within what is considered normal, so like above -2 standard deviations. Now, ALS deficiency, 3M syndrome, Russell-Silver syndrome, this is typically caused by a methylation defect, but there's a handful of cases that have been reported due to mutations in IGF-2. Those typically present with significant IUGR and SGA birth. Similarly, floating harbor syndrome. And then last but not least, Noonan syndrome can present with SGA birth, but not typically. Like most of them are usually below average, but within the normal range. Then those that have disproportionate short stature, similar to growth hormone deficiency and Laron syndrome, they tend to be below average, but most of them will be within the normal range. So I highlight it here. This is usually their mean birth weight or length. So -0.4 to 1 or maybe up to 2 standard deviations, but most of them are within the normal range. Now, those that have microcephaly, those tend to be like more severely affected and are very small at birth. So in this group, we have IGF-1 deficiency caused by mutations in the IGF-1 gene, IGF-1 resistance due to mutations in the IGF-1 receptor, and then PAPI-2 deficiency, which is really rare, and there's only like a handful of cases. So here we can see IGF-1 deficiency and resistance to IGF-1. They're very, very small at birth, and that we know that IGF-1 is a very important regulator of intrauterine growth. It has nothing to do with like the secretion of growth hormone. It's all secreted by the placenta. So when we see mutations in these genes, babies are very small at birth. Then there is a whole separate group that is primordial dwarfism. These are very severe. Typically, they have very significant dysmorphic features, and I think these are relatively easy to like identify. I think typically these patients will get referred to genetics early on, and usually we have a clear genetic diagnosis. And then of those that have imprinting disorders and methylation defects, most of them will have significant SGA birth and IUGR as well. The most common one in this group, I think, is Russell-Silver syndrome due to methylation defect at 11p15. Temple syndrome presents typically very similar to Russell-Silver, and they also tend to be small at birth. Image syndrome is very rare, but they're small at birth as well. Not so much in Prader-Willi syndrome. They're usually below average, but within what is considered normal. All right. Now, we are going to cover some of the consequences of what happens after being born small for gestational age. So in the neonatal period, I feel like us as pediatric endocrinologists very often will get involved and we'll get like consulted from the NICU. Babies that are small just have increased risk of mortality. And very, very often, about like 30% of the times, they will have hypoglycemia, and that's often why we get involved. So it is very significant, and it tends to last a while. And this happens because they don't have enough fat. So they have like overall like low glycogen stores in the liver. They have lower levels of free fatty acids and ketone bodies, which is all a result of like having reduced fat stores. So typically these can last weeks, 2 months, and the baby just needs to grow and get bigger and have like bigger stores. Sometimes we have to use medications such as diazoxide to like help. Hypothermia is another issue that happens early on. They have a relatively large head, so they tend to lose heat easily through like increased body surface. They also have increased transdermal insensible losses, and overall they have lower sub-Q fat, so they have more issues like retaining that heat. Then in infancy, typically we see like rapid catch up in both weight and height in the first few months. So like usually between 3 to 6 months is when they gain like rapid weight and length. And often they will have actually an increase in fat mass early on, and is typically greater than the increase in muscle mass. So for that reason, typically they have elevated ratio of visceral to sub-Q fat. The overall amount of total fat mass is reduced, but they have a normal amount of visceral fat and then a reduced amount of sub-Q fat. So visceral is always going to be a little bigger. And then you're going to hear me say this multiple times today. So that accelerated postnatal weight gain will increase the long-term risk of obesity, metabolic conditions, aging, and then coronary vascular disease. So that's the big thing that we want to try to avoid. We want them to grow, but we also want to try to avoid that rapid weight gain early on. Now, during childhood and adolescence, so 90% of the children born small for gestational age will show catch-up growth into what is considered the normal range. So they just have to make it to like the very low end of normal, so like -2 standard deviations to be considered, you know, normal and to like be considered that they caught up. So again, typically this is more pronounced during the first 6 months of life, and usually by 2 years of life, babies that are going to catch up will catch up, which is the reason why often we'll start growth hormone treatment as early as 2 years of life. Now, in those babies that are born preterm, it might take a little longer. So if they are showing progress on the growth curve, sometimes we want to give them a little extra time, and we can wait until they're 4 or so. To like decide if we want to start treatment with growth hormone. Now, if the height remains low, meaning that it remains below -2 standard deviations by the age of 3, they have a 7-fold increased risk of remaining short as adults. So we know, yes, even if they continue to catch up, the chances that they will remain short are very, very high. There are some factors that will influence positively the growth. And those are female sex, multiple birth when they have taller parents, and then when they grow quicker, so they grow taller or I guess longer early on in life. Other things that we see during childhood and adolescence is issues with neurodevelopment and cognition. Usually babies that are SGA will have normal pre and postnatal growth of the brain unless they have like some specific genetic conditions. But it is very clear, and there's multiple studies that show that there is an increased risk of having developmental delay, impaired cognition, ADHD, and then some learning difficulties later in life. They also have increased risk of having poor school performance that has been reported in this patient population. And then we know that the risk increases with the severity of the SGA. And then as they catch up and they grow taller, actually that risk tends to decrease over time. So those that have better catch up overall tend to have like better developmental outcomes and school performance. And then in general, we can see here, this is a meta-analysis. We can see that cognitive scores in general favors like babies that are born AGA. So this is like several studies, and like I think almost all of them except for maybe a couple favor AGA birth. Now, as far as puberty, gonadal function and fertility, some of the things that we see that are more common with females is early onset of puberty. So this is typically not abnormally early, but it's about 6 months earlier than average. So for girls, the average onset of menarche is about 12. So girls that are born SGA usually will start around 11 with menarche, but it's still, again, considered within the normal age range. The other issue is that it doesn't only happen earlier, but it also happens faster, which overall earlier puberty and rapid progression is not something that will help us with like overall growth and time really to get taller. Now, so there are some theories about why this happens. And I'll review one of these theories that have been proposed before. But basically, the thought is that there is a mismatch between reduced prenatal weight gain and then accelerated postnatal weight gain. So that is another reason why we want to try to avoid this. And this actually ends up causing increased risk of having early onset of insulin resistance, dyslipidemia, saturated adrenarche, and premature pubarchy. Then, as I mentioned, younger age at menarche, and then higher incidence of PCOS in females. So this is actually like one of the theories that has been proposed to explain why that happens. So again, they mentioned that there is a mismatch between less prenatal weight gain and then very rapid and more pronounced postnatal weight gain that results in some fat excess and overall like subcutaneous adipose tissue, but also like in visceral tissue. So they have excess deposition of like visceral fat. And then early on in childhood, we start seeing like increases in insulin release, growth factors. They make more DHEAS, which will actually lead to like early growth or accelerated growth early on, and then advancement of the bone age, early adrenarche, and early pubarchy. And they mentioned that this is kind of like a mechanism to compensate that central obesity. So they just grow faster, they get taller. And then once they go into puberty and they attain menarche, that compensatory mechanism that we had to like basically get taller and grow faster goes away. And then that's when the females end up developing like full-blown PCOS with like increased like ovarian androgens, like issues with ovulation, and then like all the signs and symptoms that we see with PCOS. So other things that might be affected in these patients but are not as relevant, and most of them stay kind of like between that window of normal, is the thyroid function. So they have higher TSH levels, and they have increased incidence of like transient thyroid dysfunction that we often see in babies. But most of them will actually not need treatment with levothyroxine. Regards to bone mineral density, they have lower bone mineral density, but typically it is between the normal range. And it is actually similar in those that have persistent short stature and those that will show spontaneous catch-up growth. Then during childhood and adolescence, we see, where did my pointer go? Okay. So metabolic consequences, they start showing signs of insulin resistance very, very early on. It can be detected as early as age 1 to like 4 years. Again, they have accelerated fat mass accumulation and then central obesity that we see in those that have very rapid and disproportionate weight gain in the first 3 months of life, and those that have a higher BMI. But usually during childhood and adolescence, we do not see increased rates of like type 2 diabetes or dyslipidemia or hypertension. These are things that we see more often later on in life. Now, in adults, so SGA babies actually have increased risk of having type 2 diabetes, hypertension, and then cardiovascular disease. They mentioned that there is like this U-shaped curve relating to the size at birth with long-term morbidity. With here is SGA, so, and then this is AGA babies, and then the last two here are macrosomic or LGA babies. So the risk we see is higher for small babies, and then for large babies, and then it goes down for those that have a normal birth weight. And usually females born SGA will have a risk of severe preeclampsia later on in life as well. So there is a weak association between SGA birth and cancer risk, and I think this comes more from a very clear association that has been linked with preterm birth and very, very low birth weight, and specifically hepatoblastoma. So there's multiple studies showing that that is the thing. So we can see here that in babies that are less than 1,500 grams, the odds ratio is 15. And those that are preterm is actually 7.4. But there's only one study, that is this one, specifically looking at SGA birth. And then for SGA birth, it's only 1.7. So compared to like very low birth weight and preterm birth, is really not as pronounced. So that's why they say that it's more a weak association. All right, so now I am going to talk about the clinical management of children born small for gestational age. So I will review mainly these guidelines that were published earlier this year. So I think this is very relevant for us as pediatric endocrinologists, and I think they also mention a couple of things to keep in mind for adults. Okay, so early on, hopefully like at one point, like we'll have our GMPs colleagues and neonatologists like on board here, because I feel the first 2 years of life, nutrition is the key. So we just have to make sure that we are providing enough nutrition just so babies will have good catch-up growth and enough just so we're preventing hypoglycemia that I already mentioned is an issue. Again, sometimes we'll have to use diazoxide if needed. And the biggest goal here is prevention of rapid weight gain, for just to prevent all the things that can happen later on in life. And I feel like this is something that often general pediatricians and neonatologists are not aware of. So these babies will be on like really like high calorie formulas. They'll be on like 28 calories per ounce, or like even higher than that, just because they want them to like gain weight and weight and weight. And then that's definitely something that we want to try to avoid. So when possible, the ideal thing is breastfeeding. That has basically everything they need, and usually that will be actually enough for them to like catch up gradually. We have to like assess early on for the neurodevelopmental delay, and then if there's anything concerning on physical exam, we want to refer early to genetics to exclude or diagnose any potential genetic conditions. So this, I'll just highlight a couple of things. I know this is very busy and I don't expect you to like be able to read this slide, but these are the recommendations for the earlier periods of life. So everything starts during pregnancy. So we want to offer good prenatal care, check for hypothyroidism, and if there is hypothyroidism, treated. Early on, we just have to like keep an eye on the weight and the growth of these infants. We want to try to avoid adding any nutritional supplementation in healthy babies up to like 6 months of life, as long as they're gaining weight. And because we all know that excessive postnatal weight gain should be avoided as much as we can. And then typically we'll see them just to measure weight and length and head circumference every 3 months during that first year of life, every 6 months in the second year of life, and then every year until they complete their growth after that. And typically when we see poor catch-up growth by age 2, meaning that they are still below -2.5 standard deviations, that's when these patients should be referred to a pediatric endocrinologist. I think it's also the job of like general pediatricians just to do early screening for cognitive impairment. All right, so in those kids that have poor catch-up growth and have significant short stature, so most of them will end up being referred to endocrinology, hopefully early on. And obviously it's our job to do a good physical exam, make sure that, you know, we'll measure like different body proportions, see if there's like any dysmorphisms or anything that will make us suspect an underlying genetic condition. We'll measure head circumference, that is important as well. And then typically we'll just get like some baseline labs to like rule out like any endocrine conditions. So we'll get growth factors, we'll get like thyroid function. Obviously, if any of these are concerning, we'll get a growth hormone stimulation test. If we see that there are any abnormality with like body proportions and we suspect a skeletal dysplasia, we can get a skeletal survey and then decide if we want to refer the patient to genetics. If we have an abnormal growth factors and we're suspecting a defect in the growth hormone or IGF-1 axis, then that's when we want to like consider sending additional genetic testing. And obviously, if there's like any clear dysmorphic features that we suspect syndromic short stature, we want to go ahead and refer early to genetics. So growth hormone treatment. So I think this is like the one thing that we have been doing for several years as pediatric endocrinologists. So it is an FDA-approved indication for growth hormone, and it's actually the second most common indication for growth hormone treatment after growth hormone deficiency. So the most important thing that will predict a good response is early initiation of treatment. So that's why we want to start these babies as early as we can. So here in the US, the earliest that we can start is age 2, and typically they have to be below -2 standard deviations. It is the same in South America. Europe and Japan actually have like more strict criteria. So in Europe, they have to wait until they're 4 and they have to be shorter. So at -2.5 standard deviations, and usually they need to have below average growth velocity. In Japan, it's like an in-between. So they have to be 3, and then typically they need to have height below -2.5 standard deviations. So as far as treatment for short stature after SGA birth, we know that growth hormone at relatively low doses induces catch-up growth, and then will improve adult height of short children that are born small for gestational age. Typically, these children that are treated with growth hormone for a prolonged period of time will gain about 1.25 standard deviations. So I think that's pretty significant. And then some of the clinical predictors that will be positive for a good growth response are having a lower height SDS at the start of growth hormone. When they have a good response in that first year of treatment, that typically shows that they're going to overall respond well. When they're exposed to a longer duration of treatment, when they have higher length SDA standard deviation at birth, and when the mom is taller. So some of the things that we can see during growth hormone treatment in regards to like glucose metabolism, blood pressure, and lipids is that we know that at baseline, short children that are born SGA have lower insulin sensitivity. And then we know that growth hormone treatment actually decreases that insulin sensitivity even more. But typically, these patients will have a compensatory increase in insulin secretion. So like overall, they're able to like maintain normal blood sugar levels, and their A1C levels remain normal. And then usually once they stop that growth hormone, insulin sensitivity will increase again, and they kind of like go back to where they were. Usually blood pressure is a little better in patients that are treated with growth hormone. And overall, there is a beneficial effect on lipid metabolism with lower total cholesterol and LDL cholesterol. So there's a lot more benefits than just like helping them grow. So as far as BMI and body composition, this is another very significant change that we see with growth hormone treatment. Typically, these babies have, on average, lower bone mineral density, and then during growth hormone treatment, that bone mineral density improves a little. And then these changes in body composition are actually significant. So they have a very significant decrease in fat mass due to the lipolytic effects of growth hormone. And they have an increase in lean mass due to like the anabolic effects of growth hormone as well. As far as like thyroid function and puberty, it will not cause thyroid dysfunction. They might have lower free T4 levels in about 14% of the patients due to like an increased conversion of free T4 to free T3, but that TSH remains normal, and like most of these patients will not need treatment. Just because of this, typically they recommend that we monitor thyroid function every year in those patients that are being treated with growth hormone. It doesn't have any effect on puberty. It does not influence pubertal height gain regardless of the dose. That's sometimes a misconception that we have to increase the doses of growth hormone during puberty to like allow more rapid growth, but it doesn't really make any difference. As far as cognition and health-related quality of life, there are growth hormone receptors present in the brain. So that tells us that potentially growth hormone treatment could affect brain function. So there are some, multiple studies actually showing that there is some, they call modest improvement in cognitive function, IQ scores, and overall psychosocial functioning. They also mentioned that it improves health-related quality of life in babies that are born small SGA. And then adolescents have higher physical abilities, contact with adults, and then overall body image. So here we can see IQ early on and after like 10 years of growth hormone treatment. So like they start with like lower than average like IQ, and typically they but by the end of like after several years of growth hormone treatment is very similar to their peers. All right, so as far as recommendations for growth hormone treatment, it is recommended that we start at 0.033 milligrams per kilo per day. For those of us that are used to like milligrams per kilo per week, that is actually a low dose of like 0.23 milligrams per kilo per week. So we start there and then we see how they respond. If they're growing beautifully and they're catching up, we don't need to increase the dose any higher than that. But if they have poor growth response and that growth velocity remains low, then we start increasing the dose. But we don't want to go any higher than double this. So like we want to stay around like 0.4 at the most. And the recommendation is to try to maintain the IGF-1 concentration below 2 standard deviations. So I would say that if you have to go higher than 0.4, it's very unlikely that we'll be able to keep that IGF-1 below 2 standard deviations. And typically, they don't recommend starting higher doses because they don't grow any faster if you start them at like double that dose. So, so this is the recommendation for the guidelines. Bone maturation is a poor predictor of timing of puberty and high prediction in kids that are SGA. So it's not recommended that we start getting bone ages early on, but typically around 8 or so, which is right before puberty, we should get a baseline. And then once they start with puberty, I think at least annually it's a good idea to get these bone ages. So this is their recommendations per the guidelines, a baseline every 3 to 4 months, then every year during growth hormone treatment, and then what we want to do at the end. So GnRH agonists or Lupron, this is what we use to treat precocious puberty, can actually be considered and can be added. Mainly the predicted adult height is going to be below minus 2.5 standard deviations at the onset of puberty. So that's why we want to get a bone age. With the bone age, we're able to calculate their projected height. And if it looks like the projected height is going to be too low, we can add GnRH agonists. So I would say that we don't want to do this any later than like age 8 to 9, probably for both like boys and girls. And in those that are treated with both growth hormone and GnRH agonists for 2 years, typically they have an improvement on average of about like 6.6 centimeters. So that's like about 2.5 to like 3 inches. And overall, in those treated with both GnRH agonists and growth hormone versus only growth hormone, there are no long-term negative effects on body composition, insulin sensitivity, blood pressure, lipids, up to like 5 years. That is the studies that we have available after stopping growth hormone. All right, then what happens after we stop growth hormone? We see like all these benefits when they're growing, and that yes, it helps, but then we stop it, and then what happens? So there is this study that was published in like JAMA Pediatrics a couple of years ago showing that there is an increased risk of cardiovascular events, basically in all adults that have been treated with growth hormone. So they look at growth hormone deficiency, idiopathic short stature, they look at SGA, and then the hazard ratio for those that were SGA was really high compared to like everything else. It was 1.97, I think, for growth hormone deficiency, and idiopathic short stature was around 1.5. But the biggest limitation and the reason why we cannot say that it's actually something that we want to try to avoid in these patients is because the controls that they use specifically for this study were healthy controls. So we know that at baseline, babies that are SGA have increased cardiovascular risks. You cannot just compare them with like healthy controls that were not treated with growth hormone. I think the ideal way to like do this study would be like comparing those treated with growth hormone versus SGA babies not treated with growth hormone. So this is a nice table that they show summarizing basically all the things that we see. So with growth hormone treatment, we see improving like fat mass, increasing lean body mass, increasing bone mineral density, decrease in insulin sensitivity, lower blood pressure, lower lipid levels. So it sounds great, but then we stop it. And then some of the things that we see in adults is that it Fat mass increases again. They have lower bone mineral density, lower lean body mass. They recovered that insulin sensitivity again, higher blood pressure, but still within what's considered normal. Higher lipids, but again, within what's considered normal. And then the prevalence of metabolic syndrome is about 2.5%. So now comparing those that were treated with growth hormone with like controls basically around like 30 years of age, they see that those that are treated with growth hormone obviously are taller than those that were not treated with growth hormone. So I think that's overall like the biggest advantage. Fat mass is similar. Lean body mass is lower basically in all SGA patients, regardless they were treated or not with growth hormone compared to like AGA patients. Bone mineral density is similar in those that were treated versus not treated, and it is a little lower compared to babies that were AGA. Insulin sensitivity and beta cell function is similar to SGA, not treated with growth hormone, and those that were AGA as well. Blood pressure is similar. Lipid levels overall are higher in all the patients that were born SGA versus those that were born AGA. So for follow-up of like those patients that were treated with growth hormone and that were born small for gestational age, I think the main thing is just like reinforce and tell them that the most important thing is that they maintain a healthy diet and a healthy lifestyle in general, regular exercise, try to avoid excessive weight gain. And I mean, this is basically what we recommend for everybody, right? And then when indicated, we want to do medical and metabolic follow-up and get labs just like we do with like all of our patients. So in conclusion, so I think this is probably the biggest slide of like the main things that we want to try to remember from the talk. It is important that we follow babies born small for gestational age in the first couple of years of life and follow their growth, their weight gain, and neurodevelopment. We want to try to avoid excessive postnatal weight gain because this will lead to multiple issues and like metabolic issues down the road. If there is poor catch-up growth by age 2 or 3, that's when they need to be referred to endocrinology. And often we will start growth hormone treatment around this time because we know that there are multiple benefits. In those that have a poor projected adult height at the onset of puberty, we can consider adding 2 years of GnRH agonists to delay the progression of puberty and just give them a little more time to grow. And then after growth hormone treatment, those young adults that were born SGA, we should just consult to work on a healthy diet and a healthy lifestyle. And that's all that I have for today's code.
Treatment, because we don't use growth hormone in adults other than hypophytic population. So the long-acting versus the daily.
So long-acting, unfortunately, is still only approved for growth hormone deficiency. Oh. So it is not an option yet. I know that they are working and they're doing a lot of research, and hopefully it will be approved for like other indications. Because yes, we get that question all the time. But as of right now, we can only use it for growth hormone deficiency.
Right. I remember when I was doing the rotation that used to be skiffy. Is that something?
In these patients, I think skiffy in general is a potential but very rare side effect of like growth hormone treatment. So yes, I would say that just like any other patient treated with growth hormone, they have slightly higher risk, but overall it's rare. So.
And with the treatment outcomes, you have seen better neurocognitive performance.
That's what they say, and it's been like multiple papers, and apparently like growth hormone even helps with that, which is interesting. So
it's a receptor.
Yeah. Sorry about a lot of growth and growth hormone and like it's a little boring for you guys. But,
No, it's good. See if there are questions there.
let's see. Stop sharing. Send these. Are there neurodevelopmental delays for SGA birth that cause behavior development in addition to cognitive deficits like talking later than normal or school performance below the curve? Does growth hormone help to catch up? Yes. So based on what I read, yes, there is definitely a difference in neurodevelopment in general in those babies that are born SGA. There are several studies showing that growth hormone is beneficial, and many patients actually like catch up pretty good with their peers. And it seems like the better the response and the better the growth, the more significant the catch up will be. And I would say that this is obviously more for those patients that don't have like any underlying genetic conditions. And I think that was the only question that we had there.
So Dr. Winters out here in the far away. Hello, that was Dr. Cabrera. That was really very good, comprehensive and informative. So for the endocrinologists, adults who are interested in PCOS, especially those who think of it as a neuroendocrine disorder. So the question is, to me, are all of the subtypes of SGA have the increased risk for PCOS? Like, for example, the babies born to smokers or mothers who are sick? Or is it those only where the moms had the metabolic syndrome and diabetes, and that's the reason for their SGA? Is that sort of parsed out?
No, so I think that the increased risk of like metabolic conditions and like premature adrenarche, early puberty, then PCOS later in life is in general for all babies born small for gestational age. So I think regardless of like the mother's history of what caused the SGA, most of those babies will have increased risk of having that down the road. So I don't think, I don't know if they've looked specifically of like, you know, the different things that cause SGA. Is more generalized.
Well, I mean, not all women who have insulin resistance and cardiovascular risk get PCOS. So there's some other genetic story there. So the question is to parse that out specifically, whether all of those groups of SGA children are all similarly at risk for PCOS, yes or no. So that's my question. Not about the metabolic syndrome or obesity, but PCOS specifically.
PCOS specifically, females born SGA will have increased risk in general. Yes.
Okay, thank you.
You're welcome. Okay, I have some questions about bariatrics. Oh no, this is old. Never mind. Okay, I was like, yes, I think that's it. All righty. Well, thank you, everybody. Enjoy the rest of the afternoon.